A very good afternoon to everyone. I'll be presenting my paper on trials and tribulations of pneumatic retinopexy, where I'll be discussing about the incidence and outcome of perioperative and post-operative complications. We all know that pneumatic retinopexy is a non-invasive and minimal procedure which is used for primarily uncomplicated retinal detachments with minimal PVR. Single operation success rate in various studies has been shown to be around 45 to 80%. The functional outcomes, however, of these eyes repaired successfully, these exceed those of scleral buckling and pars plana vitrectomy in many cases. This study was planned to report on the anatomical and functional outcomes in uncomplicated retinal detachments of pneumatic retinopexy, as well as report on the perioperative and post-operative complications as well as their management. So this was a prospective observational case series study where patients undergoing pneumatic retinopexy were enrolled in the study. Any patients which were younger than 18 years or any pre-existing conditions that would preclude them from maintaining the desired posture were prohibited from the study, as well as significant PVR-C was also an exclusion criteria. The pneumatic retinopexy was performed within 24 hours of the presentation of the patient, and using the protocol that is described in the pivot trial. All the patients were instructed to perform initial face down posturing, and macula on cases they were instructed for 4 hours prone positioning as well as 6 to 8 hours in macula off cases, and which was followed by the steam roller maneuver. Patients which completed a minimum follow-up period of 3 months were enrolled. This is the basic demographic details of the patients. The mean age was around 50. 18 of the we enrolled a total of 27 eyes of 27 patients. 18 of these eyes were macula off and 9 were macula on. 18 eyes were phakic and 9 were pseudophakic. Almost 37% of our cases were two quadrant, like half of the retina was detached, and 6 each eyes of 3 and 4 quadrants were involved. Mostly we preferred SF6 as a tamponade agent. Only in few cases C3F8 was used. And whenever possible, we applied both cryopexy as well as laser retinopexy, but in certain cases where we could not, then laser retinopexy was the preferred modality. So retinal attachment was achieved with single pneumatic retinopexy in 21 of the 27 eyes. One of the eyes underwent a second retinopexy procedure, so that the success rate was 81.4%. 5 of the eyes had to undergo pars plana vitrectomy with gas or oil tamponade. The reattachment rate with the second procedure was 100%. So this is the improvement in the logMAR best restricted visual acuity that we saw from pre-op to 1 week and 3 months post-op. So now I'll briefly discuss the complications that we encountered. Fish eggs of the injected gas was the most common complication, which was encountered in 5 of the 27 eyes. The main problem is that this will preclude the laser therapy to the break area. However, it can be forced to coalesce using the forceful tactile stimulus, but in almost all the eyes we saw that within 24 to 48 hours the bubble coalesced on your own, and there was no correlation with final success rate or visual acuity. Another complication was noted in pseudophakic eyes as well as high myope eye. One eye was a pathological myope with weak zonules. There was gas in the anterior chamber. This was managed out by expressing the gas and forming the anterior chamber with Helon and re-injecting into the gas bubble in the vitreous cavity up to the desired volume. One of the patients also suffered from a cryoburn, which was due to an inadvertent injury due to the sleeveless cryoprobe, but this was managed with topical clobetasol and silicone gel, and the patient had minimal scarring. Subretinal gas was noted in one of the eyes, which had a large superior retinal dialysis of more than 2 clock hours. This was managed with supine positioning and expressing out the gas using a scleral depressor, following which the laser therapy was possible to the break area. Vitreous hemorrhage was also noted in one of the eyes, and this precluded laser therapy. However, we'll be able to mostly laser through the bubble. As you can see in this case, the media is hazy, but after a while you can laser through the bubble. Choroidal detachment was noted in one of the eyes. This was a pathological myope. This patient suffered from choroidal detachment. Initially the retina was attached, but she suffered from a redetachment a month later, which had to be managed with pars plana vitrectomy, during which we found that there was vitreous traction along the superior area. Post-operative complications, we saw that there was persisting subretinal fluid, which was noted in 3 eyes. This patient presented with a macula on RD, and after injection of the gas ball, we see that there is a fluid collection inferiorly. And we saw that there was also formation of a lamellar macular hole in this patient with inferior subretinal fluid which was persisting, but this was not associated with significant worsening of the vision. This is another case which had persisting subretinal fluid, but there were no outer retinal corrugations, and the patient had a vision of 660, and we are following up this patient. This was a patient which had a temporal break, and this was managed with pneumatic retinopexy, and we see there's a small neurosensory detachment at the foveal region. This patient had a vision of 612. We also saw that 33% of eyes with macula off RDs complained of micropsia or metamorphopsia compared to only 2 eyes in the macula on group. The redetachment was seen in 6 eyes, where we saw that the most common reason was that the break was below the horizontal meridian, which was an adventurous decision on our part to undertake pneumatic retinopexy. In most of the cases, others we saw the persistent traction on the break side, and there was a missed break as well as creation of a new break. This is one of the patients that had a failed pneumatic retinopexy. You can see a large horizontal tear. Initially there was attachment, but the patient suffered from a redetachment, which had to be taken up for pars plana vitrectomy. This was another of patients where we see that though we were able to laser the superior area, but inferiorly the fluid was subsistent, significantly persisting, and the patient had to be taken up for a pars plana vitrectomy. This is a remarkable case that the patient had a Strassmann syndrome with myelinated nerve fibers, and he presented with 360 degree of choroidal detachment as well as retinal detachment, and we see a supratemporal break in this area. And this patient, we were able to inject almost 1.5 cc of SF6, and the patient had a retinal detachment. However, the vision did not improve more than finger counting. So we conclude that it is an indispensable tool for a VR surgeon. The complications are frequent, but they can be tackled effectively with little bearing on the final outcome, and anisoconia is mainly related to the preoperative macular status. Thank you.
Thank you.
Did you encounter any case of raised intraocular?
Post-op day 1, none of the cases that are persistent managed medically. Most of the patients I saw, they had post-op elevated IOP mostly till day 2 or 3, but after 1 week there was like normalization of the IOP. None of the patients had significant, none of the patients needed any anti-glaucoma drops more than like 1 or 2 weeks. After that we were able to normalize the IOP, because that is the time that we look for.
What's remarkable was that the subretinal gas, you were able to manage it without a second procedure.
Yeah.
Thank you.